Good evening, and thank you for joining us for the patient education series of 2022 of the Comprehensive MS Center. Tonight, our topic is Black Americans and Multiple Sclerosis Update 2022. Let us switch to an additional consideration in today's program, and that's the concept of what do we want to do in multiple sclerosis? How do we manage multiple sclerosis? And obviously, in order to do this, we need to have kind of a roadmap. We need to understand what we would like to do. Ideally, I would like to control a patient's disease in a way that MS is dormant. I mean, ideally, we will cure multiple sclerosis, but that's at this point in time, probably not yet possible. So we would like to reduce the number of relapses or have no relapses. We would like to have none of the new lesions, and we would like to have no disability progression in individuals. Obviously, the more we want, the more difficult it's going to be to reach that particular effect. We also need to know where we come from, and there have been several studies looking at patients with the first demyelinating event, with the first MS attack. Why do I show you this particular slide? I show it to you to tell you what happens in such patients, and these studies have been performed over an almost 20-year time interval. What you're seeing is that if not treated, the patient after a first event, about 40% or so of the patients will have a next attack. If I were to tell you that a person has a 40% risk of having a heart attack in the next year, or in the next 2 years, because they had already an event, you would obviously be up in arms and you would do a lot of things to prevent this event. This is also what we need to do in multiple sclerosis, because as I have already introduced to you, multiple sclerosis is not just demyelinating, so it doesn't just strip the myelin and then the myelin comes back. It also leads to nerve injury, and we know that many patients face a risk of having a next event, and so therefore early treatment is really what we try to achieve. And this is shown over here. If the red line, the dark red line, is natural history, that's what we would like to change. And obviously, the sooner we intervene with the disease process, the more likely is it going to be that we have a course of the disease that is closer to the state of health, where MS is not going to impact the person's life in a significant fashion. And so at this point in time, it's the recommendation of the Academy of Neurology, of the MS Society, of all the organizations that are caring for patients with multiple sclerosis, to really start early with treatment right at the diagnosis of MS. MS is not a disease where if you don't bother it, it doesn't bother you. MS will bother many individuals, and MS, there needs to be a foot on the brake once a person has been diagnosed with MS. The good thing is in multiple sclerosis, we have multiple agents that are directed and help us to control the imbalance that I showed you, to control the disease process in MS. None of these interventions is curative, none of them is a cure, but all of them have benefits. And it's obviously then in the discussion of the individual patient with his or her physician to actually make the best decision possible. When I think of individuals of African descent, then I also think of the fact that often at the time of the diagnosis, more disability is already present than potentially in Caucasian individuals. In any individual where more disability is present at the initial presentation, obviously our concern needs to also be to use most effective medication early on, because we already know that the disease process can have a significant effect on that particular individual. Now, when we think of multiple sclerosis, we have different medications. They are also differently given. Some of our medications are proteins, and proteins need to be given by administration, such as injection or by intravenous administration, because they cannot be given by mouth, because they would not survive the stomach. Versus there are other medications that are small molecular entities. These are small molecules. They can go through the stomach, and from that point of view, they can be orally administered. Kind of another treatment that is a multimodal treatment, because it includes different medications and different approaches, is hematopoietic stem cell transplant. Obviously, many individuals view potentially as hematopoietic stem cell transplant as a potential cure for MS. Now, when an individual says it stops MS, it doesn't bring back what the person has already lost in function. It may only hold the disease process. But even in stem cell transplant, still a significant number of individuals will have some degree of disease activity, and progression that is there because of prior injury of nerve cells is not going to stop just because one has a stem cell transplant. So when an individual hears it cures, it doesn't mean that it restores. And so when we think of MS treatments, then we have treatments that are ongoing, where a person needs to either take a daily medication by mouth, or shots 3 times a week or every month. Or we also have medications where we give medication that's much less frequently, sometimes just once, like in the stem cell transplant, or in 2 cycles over 2 years, such as some of the oral medications. So I mentioned that the autologous stem cell transplant is an attempt to reboot the immune system, to bring it back from an autoreactive, a self-reactive state, to a state where the individual is again not the individual's immune system is not attacking the person. And I mentioned that at this point in time, we still not need clinical trials that actually compare stem cell transplant to best available treatment in this individual. We also need to understand what it means long-term, not just 5 years, but 10 years and 15 years with respect to return of disease activity, and potentially also occurring of immune consequences, particularly if a person's immune system ages, and whether then there are more cancers occurring or whether other complications could be present. And this is what, in a graphic way, what a treatment like bone marrow transplant would like to achieve. It would like to take a situation where the immune cells attacks the person, to allow, by resetting the immune system, for a new immune system to emerge that is no longer attacking the person, to essentially reconstitute an immune system that is not reactive with this particular individual. Obviously, when we are talking about treatments, there is also the middleman present, and these are the insurance companies and the specialty pharmacies, and sometimes it's then important to understand some of the terminologies. because very often formularies change every year, or a medication may be on and then a medication may be off next year. And insurance companies may also prefer certain medications. That's called step edits. They may eliminate the medication from their formulary and not allow the patients to continue. In the past, individuals that were on a medication were allowed to continue such medication. That's called grandfathering. And very often, insurance companies have brands as preferred instead of groups of compounds, because as I showed you on the prior slide, certain different medications may belong to the same family. And particularly if a patient with multiple sclerosis already had experienced one member of a treatment family and had breakthrough disease with that, it would make little sense for that person to be again on that particular same formulary. When I think of multiple sclerosis, diagnosis is one part. Selecting a treatment or selecting additional treatments is another part. Ongoing management of DMS is a very important part because we have a lot of symptom management to do. And as I already mentioned, with the spinal cord, for example, spinal cord can lead to spinal cord injury can lead to bladder dysfunction. It can lead to walking difficulty. It can lead to problems handling objects and doing things. And so from that point of view, in multiple sclerosis, many different symptoms can occur. And it's important that all of these symptoms can be, to a degree, addressed. And so when we deal with multiple sclerosis, we also deal with symptom management, and we deal with symptoms that change over the course of the disease of an individual. How do we achieve this? We achieve this through a multi-specialty approach with urology, neurology care, social work, rehabilitation, but also mental health providers that are there. And as always in all of this, it's important to drive the field forward with research and new understanding in our field.